Καλησπέρα σε όλους. Συγχαρητήρια, ευχαριστούμε πάρα πολύ που μας έχετε εδώ σήμερα. Ευχαριστούμε πάρα πολύ τον κύριο Δρακούλη. Όλο το επίπεδο όλων των προηγούμενων ομιλιών και παρουσιάσεων ήταν εξαιρετικό και είναι πάρα πολύ ωραίο και ενδιαφέρον το γεγονός ότι κάνουμε hosting ένα συνέδριο Precision Medicine στην Ελλάδα. Λίγα πράγματα για μένα. Ονομάζομαι Έφη Σαλάτα. Είμαι μοριακή βιολόγος. Το background μου είναι Developmental Medicine and Reproductive Medicine και αυτή τη στιγμή δουλεύω ως Medical Science Liaison σε μια εταιρεία βιοτεχνολογίας και ανατομίας και βιοτεχνολογίας, την iDNA Laboratories. Οπότε σήμερα θα μιλήσουμε για την πρόληψη στις καρδιαγγειακές παθήσεις και πώς αυτό μπορεί να γίνει μέσω της γενετικής. Από εδώ και πέρα θα συνεχίσω στα αγγλικά. Δώστε μου μισό λεπτό. Λοιπόν, to begin with, let's review the problem which is more or less known. Based on the latest data from the European Society of Cardiology, as we speak, 3.9 million people are dying from cardio diseases in Europe only. Two of them are under the age of 60, which is accounted as a premature death, and actually, cardiovascular diseases are the leading cause still of premature mortality. What is new is that nowadays, a fraction of those deaths could be prevented through personalized and timely prediction measures. From all the fields of precision medicine that we have analyzed so far on this stage, we will focus here on the genomics section, and more specifically on the risk assessment and its stratification on the general population. The challenge today is that physicians assess a person's risk, cardiovascular risk, only on phenotype characteristics such as blood exams, lipidemic and glycemic index profile, and lifestyle factors. Therefore, a risk is underestimated for a significant proportion of the population. This is widely acknowledged, actually. I mean, all the cardiologists know that, they discuss that between themselves all the time. And the only way to further prevent even a fraction of those early deaths and diagnoses is through early detection. How come? Genetics can now help us on that. And the latest developments that we will analyze further on allows us the determination of a person's genetic load, and it's important to emphasize that genetic predisposition can be addressed earlier than any other risk factor. This means that well before imaging or biochemical tests categorize each of us in a specific risk group, we can diagnose the genetic predisposition. And this is possible through polygenic risk scoring, or PRS, as we're going to refer to it from now on. For even greater personalization, the combination of genetics along with the phenotype gives us a new score, which we call adjusted PRS. This information can help the doctor to create a totally personalized prevention plan to delay or even avoid the cardio disease. This novel tool was developed by our team, and any changes in lifestyle will be reflected in the adjusted PRS, offering the doctor a possibility to continuously monitor the individual scores of health. I will skip that. We all know what a SNP is in this room. So, a risk allele can be either protective or predisposing. A risk allele is actually a SNP. Low risk alleles have a low effect, as it makes sense, but cumulatively, they have a significantly larger impact. So the risk for numerous common diseases, such as cardiovascular diseases, arises from the interaction of common low-risk variants. GWAS is an advanced that allowed us to pave the way for novel genetic applications in the clinical practice. The aim of GWAS, Genomic Wide Association Studies, was to find statistically significant associations between a disease and a set of SNPs. So, to clarify the landscape a little bit, let's get to another concept of genetics of diseases, which is the concept of monogenic mutations. It's a concept that most of us are familiar with when we refer to genetic background of a disease. Let's say, for example, cystic fibrosis, which is a well-known disease of genetic background. This disease is actually caused by rare mutations, that's why it's called mutations and not variants, of high risk, usually a gene that affects protein expression. On the other hand, in contrast, we see a disease with a polygenic background, where the patient carries multiple low-risk variants. Common diseases, cardiovascular diseases, have such a genetic background. A good example comes from a 2021 epidemiological study where among patients with early onset myocardial infarction, or actually heart attack, only 1.7% were of monogenic etiology, involving actually mutations in a single gene, while 17.3% are attributed to polygenic causes, the so-called common variants. So actually, what is a PRS? The term. It's the weighted sum of a number of risk alleles carried by an individual as detected in published GWAS studies. What we were interested in is to be able to detect this fraction, the high-risk region, the high-risk individuals, through primary prevention. And it's important to be able to do so because those are the people who are most likely underestimated in the current assessment tools. So, essentially, with a sample of buccal swab, which is genetically analyzed, along with the completion of a validated questionnaire from the American Heart Association, which assesses the current cardiovascular health status, a report is produced. In this report, PRS and adjusted PRS is determined for each individual for each one of the most common cardiovascular diseases. Here is an example of a patient's report. We see that this individual's PRS is at 80%, but when the phenotype and the lifestyle comes into the equation, the adjusted PRS poses the person in the intermediate risk. It lowers, you see, the adjusted PRS. Still, though, the genetic predisposition of this individual is high. I mean, a clinician should be aware of that fact, because at any time, the lifestyle can change, any phenotype factor can change, so the genetics is always there. So, a little bit about the clinical evidence that support from the literature, the clinical utility. There is a plethora of literature supporting PRS, and the field is actually a field of ongoing research to reinforce the clinical utility of this tool in order to find its place in the clinician's toolbox, in the everyday clinical practice. Regarding personal utility, it makes sense that knowledge of PRS allows early initiation of preventive measures, the required lifestyle modifications, and actually informing close relatives of individuals of high PRS, thus raising awareness. In 2018, a publication in Nature Genetics reports the rate of prevalence increase for coronary heart artery disease and atrial fibrillation this time in accordance to genetic risk. You see that after the 80th percentile, see here and here, of polygenic score, there is a 3 to 5-fold increase, which is big in population genetics, in the diagnosis likelihood. Previous studies suggest that the use of PRS improves the risk underestimation until we get to 2021, when the European Society of Cardiology guidelines refer explicitly to PRS as a risk stratification tool and its utility in the use of genetics in prevention. An additional benefit arises from improvement in compliance and arguably in efficiency. People who are aware of the PRS, and especially those who are high risk, demonstrate a higher compliance with treatment, medicines, or even positive lifestyle changes. The benefits of primary prevention are higher in high-risk individuals, and according to the diagram here on the right, high-risk people with a bad lifestyle, an unfavorable lifestyle, are those who in imaging tests show higher scores of coronary artery calcification, which is a well-established clinical marker that diagnoses coronary artery disease and its degree of severity. So it's a linear correlation of high PRS with high calcification of coronary arteries. So, the first epidemiological data were obtained from our team's analysis in Greek population and were turned out as expected just from theory. The PRS data were calculated for a healthy Greek population sample of 447 people, and we examined the risk stratification for a series of common cardiovascular diseases. As you can see, the PRS was distributed to 3 risk categories for its disease: low, intermediate, and high. So our stratification data suggests that we can actually identify a percentage of the population that is at high risk and could thus benefit from lifestyle changes and a preventive medicine approach. Following that, the stratification of the risk was again examined in a randomly selected asymptomatic Greek population, where the PRS, and this time also the adjusted PRS, was calculated in the context of a descriptive statistical study conducted by a group. It is interesting to note that both in coronary heart disease and stroke categories, it was high body mass index and smoking that were associated with significantly higher adjusted PRS. What we see is that the implementation of both markers, PRS and adjusted PRS, in clinical care would enable and further empower personalized medicine approaches in this field of diseases. Finally, let's see the cost of this thing. A few weeks ago, our group conducted the cost-effectiveness analysis. Our goal was to evaluate the economic value of PRS examination through a cost-utility analysis and provide an initial estimate of its potential benefit as a screening population tool. So healthcare costs were predicted, and QALYs, which is a qualitative measure of health, were estimated in a cohort of 45-year-old Greeks without previous diagnosis. We assumed an annual cycle with 4 possible health states and a 20-year horizon. The results were that over a 5-year horizon, an estimated 40,000 new events we account for coronary heart disease and stroke, could potentially be prevented, which also leads to 17% fewer deaths. And the cost of these events correspond to more than 150 million euros that could be avoided, which indicates the need to consider and evaluate a targeted, personalized national screening program. And that's what we aim to do. Thank you so very much. I tried very hard.
Any question?
Okay.
Yes.
Thank you.
We are going to the next speaker. Is Έφη Σαλάτα?
Oh, Salata was the previous?
Oh, sorry. Stella Ravani. Hydrogen sulfide and cardioprotection.